to the second sessions. The session is the moderator is myself. So I just introduce myself. I'm the professor in School of Dentistry and the Institute of Oral Medicine in National Cheng Kung University. So the speaker for the second session is Dr. Kai-Yuan Hsiao. Dr. Hsiao is a graduate from Kaohsiung Medical University. And after he became a resident, he received the training of the specialist of oral maxillofacial surgery in NCKU hospital. And finally, he achieved the specialist board of oral maxillofacial surgery in Taiwan. And Dr. Hsiao is also interested in to study the sleep medicine. So he has been certificated as also the specialist in the sleep medicine. So like the treatment of OSA, severe obstructive sleep apnea syndrome. So he also has experience in using ACRO membrane to repair the wound of in the maxillofacial surgeon. Today, his topic is to comparing the outcomes of applying collagen matrix and the sleep sickness skin graft in repairing buccal mucosa defect. And I have to report one good news, because Dr. Hsiao's wife just delivered her little baby in hospital. So Dr. Hsiao had to be accompanied with her. So the speech is in a pre-recording form. So, but later he will return and attend the question and answer session. Okay, let's start.
Good afternoon, everyone. 早午安. This is Kai-Yuan Hsiao from National Cheng Kung University Hospital, Taiwan. It's so nice to be here to share my own experience of applying collagen matrix in the repair of buccal mucosa defect and its comparison with split thickness skin graft, STSG. And I'll start with how a wound healed with STSG, followed by how we apply STSG and APC Cola, which is the brand name of the collagen matrix we used. Finally, the comparison of the outcomes from the two groups.
How do we manage a defect? If a defect is not big, primary closure can be obtained most of the time. And sometimes, we will let the wound heal by itself, such as an extraction wound or a tongue defect after partial glossectomy. Delayed closure is utilized when there is an infection concern. For example, an animal bite wound or the first-time approach to a necrotizing fasciitis. However, if there is any functional or aesthetic need, or if we want to avoid complications like severe wound pain or infection, a repair or reconstruction is therefore necessary.
To answer the question, Mathis and Nahai first introduced the concept of reconstruction ladder in 1982. The goal of this ladder was to allow surgeons to consider options for wound closure in a systemic way. The rungs of the ladder arranged procedures from simple to complex in ascending order, and the surgeon climbed as far as necessary to bring the goal of wound closure just within reach. That means to find the simplest procedure suitable for any problem. It was thought to increase the reliability of outcomes and decrease morbidity because it eliminates unnecessary complicated strategy.
Alice, there's no animation.
However, a wound reconstruction is not
Is it
just
right?
a tap of wound closure. The restoration of function and aesthetic should also be considered, as the advance and raise of success rate of free flaps, a trend to skip the roll run for better outcome has formed. For example, in a composite mandibular defect, one may choose fibular flap rather than a regional flap for better function. But when the wound is not quite big, a split thickness skin graft, STSG, is a simple way to obtain wound healing and meanwhile minimize function deficit. How to use it? Let's review the basic knowledge of skin graft healing process. After the skin strip out, the nutrients should be obtained by a process called plasmatic imbibition within 24 to 48 hours. If the graft survived, the second stage is inoculation, a process to establish anastomotic connections. The neurovascularization usually complete in 3 to 5 days. At this time, the graft is initially stable. Then the graft will undergo remodeling for months. Understanding the healing process, we know the key for a skin graft to survive depends on establishing blood supply from the recipient bed. The following tissues are poor candidates as a recipient bed, such as cartilage, irradiated tissue, fibrosis, foreign or crushed or non-viable tissue. Besides vascularity, the route for neurovascularization should not be too far or unstable. For instance, the bleeding-induced hematoma between the graft and recipient bed can push them apart. Procedures like delay grafting, placing pressure dressing, or make some drainage pinhole, like the picture showed, are simple solutions. In addition, the graft may be mobilized by outer shearing force. It can be prevented by good suturing technique or dressing fixation. To sum up, the STSG derives its nutrition initially from the tissue fluid and later by growth of capillary buds from its undersurface. Any sliding movement or hematoma below the graft jeopardizes the graft's survival. So the key is to make it immobile. The other factors can be ascribed to the host general condition, which inhibits in-tissue oxygenation and wound healing, namely autoimmune disease, hematologic disorders, diabetes mellitus, poor nutrition, smoking, corticosteroids, and chemotherapy. The differences between STSG and FTSG is the degree of dermis involvement. The latter involves full dermis, including subcutaneous tissue. The STSG can be classified as thin, intermediate, and thick STSG. In our department, we use intermediate one. Another concept is that the thicker the tissue, the more nutrients or oxygen it needs. As a result, the survival rate of STSG is higher. However, the thicker the skin, the less the contraction, and the stronger the protection and better cosmetic result. In children, only FTSG has the potential to grow with the recipient site. The complications of skin graft include necrosis, especially when exposed to smoke because it makes blood supply and oxygenation drop significantly. Infection. This is rare and usually from stitch abscess or allergic reaction to antibiotic ointment. Bleeding and hematoma, which may result from the coagulopathy status of patients or surgery and care issues. Wound dehiscence is correlated to inappropriate suturing technique and tension control. The last, scarring, is inevitably occur in donor site. And if the skin graft failed, that means the original defect will heal by secondary attention, which lead to severe scarring. Now let's go to operating room. In our operating room, we use Zimmer dermatome to harvest STSG. It's rather easy to get a beautiful skin graft with even thickness compared to scalpel method. After harvesting, the donor wood is best covered with balsamine gauze for hemostasis. In our hospital, we like to harvest intermediate thickness STSG because it's not too thin and not too thick. It has good survival rate and provides proper protection. After thin skin graft was positioned, we use transbuccal sandwich method, and I will explain it later. Or sometimes we use tie-over method for fixation. To avoid problems like food impingement, friction, or difficulty in maintaining good oral hygiene, some surgeons will ask the patient to feed with an NG tube. And the NG tube will be removed with the fixation 4 to 7 days after the operation. And then we began to ask the patients to mouth opening training. Here's a case with left lower labial mucosal dysplasia. And this is after the tumor excision, we sutured STSG over it and do transbuccal compressive fixation. The transbuccal sandwich fixation was set as illustrated. The STSG was in close contact with visco gel and compressed with eye patch. The eye patch was poured into skin with silk suture, and the suture goes through Narraton tube before they were tied. The Narraton tube was used to dissipate pressure from suture. If you don't want to use this method, or in some impracticable places such as palate or tongue, an alternative method is tie-over dressing. This method, the sandwich method, is similar as this illustration. The post-op care of skin graft is simple: oral hygiene maintenance, selective NG diet to make oral care easier, and minimize the movement of the graft. On the post-op 4 to 7 days, because the vascular anastomosis is already established, the dressing could be removed. And a question: is cancerous bone a suitable recipient bed for skin graft? Yes, this photo shows a well-taken STSG on the cancerous bone. And we can see it became mature after 6 months. And it's very beautiful taken, right? Here are some examples of STSG in buccal mucosa, mouth floor, and ventral tongue. Okay, note the photo at the third quarter. The skin graft presents neither skin appearance nor a scar. It happens sometimes, and it is soft and stretchable. And the STSG is over a buccal fat pad lining. Even though STSG can yield with good results, the main concern of it is the donor side morbidities, like pain, bleeding, scarring, and rarely infection. These are frequently questioned by the patient. Hence, thanks to the advance of biomaterial, now we have another option, collagen matrix. This photo shows a healing wound with collagen matrix over 6 months. Apparently, a large extent of scarring was generated, but the mouth opening is still adequate. The collagen matrix we use is ABC Colla, which is a cellular matrix derived from porcine. It is a firm, sheet-like material, and the adaptation is also good because it will be softened after dampening with normal saline or blood, which makes it flexible as the picture showed. Okay. The clinical applications includes wound care, soft tissue augmentation, tendon repair, breast reconstruction, biomaterials substitute, and so forth. Here's the physiological interactions in the application of collagen matrix on a diabetic skin wound in rats. By using collagen matrix, the wound repair process is accelerated by increasing the proliferation of both keratinocytes and fibroblasts and modulating epidermal regeneration, anti-inflammation, collagen production, and cell proliferation. So, now let's look how we do the collagen matrix in the clinical pictures. This patient had verrucous hyperplasia over his left buccal mucosa, and he received a tumor excision, including marginal mandibulectomy. After the resection, pedicle buccal fat pad was transpositioned to fill into the defect and then covering with collagen matrix. Okay. Then here's the result. And this is another patient who received tumor-wide excision. Similarly, we use buccal fat pad and collagen matrix to restore the volume and integrity. Again, after the lesion was removed, pedicle buccal fat pad plus collagen matrix, then transbuccal fixation as we do with STSG. This 61-year-old female was diagnosed with squamous cell carcinoma over her right lower gingiva this year. A stage 4A was considered because of mandible invasion. The patient ever had tongue and right buccal cancer in 2003 and 2015. So this was the third time she got oral cancer. She was very, very depressed and didn't want to receive surgery anymore. But as we know, for oral cancer, it is surgery that yields a promising control rate. CCRT is for someone who is contraindicated for surgery. Then she asked me if I can minimize her physical burden and discomfort. That's why I suggested her to try collagen matrix. After discussion, she finally accepted my surgical plan. We did right supraomohyoid neck dissection and sampled some lymph nodes for frozen examination. There was no malignancy noted in those lymph nodes, so we continued to do tumor excision, which included a marginal mandibulectomy via ACRO approach. The reconstruction plate is added for reinforcement. Note that the right submandibular gland is preserved. That's because we believe that if the submandibular gland can be preserved, it could benefit in the patient's quality of life. Actually, we have just published an article about this. This is the tumor specimen. I usually peel off the tumor from bone if the bone invasion is not obvious from CT scan or panoramic view. And it was a key point to ensure our safety margin is adequate. In this case, we can see only the alveolar crest here was eroded, okay? But the invasion depth is not deep, so that means a marginal resection is sufficient. Then we try primary closure for the wound, and in the residual defect, we use buccal pad and Collagen matrix, ending with transbuccal fixation. On the post-op 3 months follow-up, we measured a 36 millimeter mouth opening. Although we can see some scarring is there, okay? But I think for a T4A category case, the result is good enough. The patient was also happy because the result is beyond her expectation. The good result also contributed from the patient's compliance. She is really, really diligent in practicing mouth opening. And I think she can achieve more mouth opening in the future because every time I saw her, there was trace improvement. So how we do mouth opening training after the operation? According to my own practice and feedback, a total of an hour per day of put into limit mouth opening is sufficient. For example, 15 minutes 4 times, or 20 minutes 3 times a day, or other equivalents are all okay. This lever is just like what we do in yoga. The body is stretchable as long as we know how to train it. To avoid injury and pain as possible, I recommend to train the healing soft tissue incrementally. Tongue depressor is an excellent tool because each has a thickness around 1.5 millimeter. The patient can then receive a feedback if he or she has any step forward or backward. Also, it's not expensive tool and it's very easy to set a goal. For example, 30 sticks, it equals to 48 millimeter in this case. It's quite wide. Now we have 2 wound repair methods, STSG and Collagen matrix. What's the differences? First of all, STSG is an autograft and it is technique sensitive to harvest it, apply it, and fix it. Surgeon will also feel stressful because they will create a donor wound in the patient's body. Collagen matrix, on the other hand, needs no donor site but money. The contraction rate in STSG is about 25%, and in college group, there is no data yet. However, in my opinion, I consider it has strong correlation with mouth opening training. In the issue of protection, the thicker the STSG, the more protection. But for collagen group, I think it's good until fully degraded. In cosmetics, STSG is just skin-like, and collagen revealed slightly pale pink to totally white scar. I can't tell what's more beautiful because everyone has their value. Now let's talk about the price. In Taiwan, people don't have to pay extra money if they receive STSG procedure. However, a collagen matrix can cost about 8 to 20,000 NT dollar. That's equal to 6 to 15 million Vietnamese dong. Depends on the size of collagen matrix they choose. Since we don't know the contraction rate yet, I collected my own cases to answer this question. Now let's look at my study. Patients with oral mucosal defect and repair with STSG or ABC cola were collected. They were all followed over 3 months to obtain a relatively stable wound condition and were all operated and received further care by myself. Under the circumstances, a total of 7 ABC cola and 6 STSG cases were enrolled in. Here are the parameters I monitored. Let's first take a glance at this table. You can see that except for only one patient who had a reduction of MMO to about 40%, most of them had less than 25% of wound contraction, or even larger mouth opening obtained after the surgery. As a result, we can probably say that both groups have acceptable outcomes, although STSG group seems to result in better mouth opening. Now let's take a look at what happened to case number 13. This 71-year-old male had squamous hyperplasia with atypia over his left buccal mucosa. He received tumor excision and wound repair with buccal fat pad and STSG. However, the STSG wasn't taken by the wound bed very well. Only a small portion of STSG survived. The patient said that he did the mouth opening training every day, which I cannot prove though. But if that's true, I think the partial uptake might account for the obviously reduction of post-op MMO. Look back on this table. The order is ranked according to the change of MMO. We can see that larger defect seems to have a better post-op MMO. The same in STSG group, but I must say that the sample size is too small to make the conclusion. Another finding is that pre-op oral submucous fibrosis (OSF) seems to contribute to the increase of post-op MMO. Yet the sample size is too small, but I guess maybe it's because the submucous fibrosis is also released during the excision of the main lesion simultaneously. Finally, the main purpose of using buccal fat pad is not only to restore some volume, but also as a cushion and second barrier for the wound bed. The effect in MMO is still unknown. In conclusion, from these cases, we can see that collagen matrix could be a reliable substitution to STSG, especially if donor site morbidity is concerned. The fear and avoidance of another wound and the pain was the most common reasons why the patient chose to use collagen matrix. However, utilizing collagen matrix also results in more scarring, which makes mouth opening limited. As a result, the key of avoiding trismus is mouth opening training and mouth opening training and still mouth opening training. I say 3 times because people in Taiwan sometimes like to repeat the most important thing 3 times. Okay, in the end, I must say that this study has small sample size. So in a total of only 13 patients, it needs more cases to clarify the above conclusion. Now it's supposed to be time for questions and answers. I've pre-recorded this because I'm afraid that I can't be in this online meeting. Here's some questions I thought you might be interested in. The first question, does post-op MMO increase in response to mouth opening training? My answer is yes, post-op MMO will be maintained, even enlarged in some circumstances, only with persistent mouth opening training. And this effect will fade out with time as scar maturing. In general, the MMO will be stable 6 months post-operatively. I think the phenomenon corresponds to the time a scar being mature, and any extra effort paying after that time may have less effect. So, to have best results as we can, I would say try the best at the beginning and had better keep going. And this is true from the feedback my patients gave me. Two, how do I decide to use STSG or Collagen matrix? There is a concept called shared decision making. That means you have to inform your patients adequate information of treatment option 1, option 2, or more, and help the patient to choose what's their preference. As such, I will compare the pros and cons of each method and let the patient make final decision. But in some situations, I would prefer one more than the other. In a severe scarring wound bed, applying STSG after scar release might be better because we don't want additional scarring recurred. And that's what I saw if Collagen matrix is applied. But if there is insufficient donor site to harvest STSG, or if there is tattoo, or if the patient is prone to keloid, then Collagen matrix might be a better choice. Here's my affiliation. Please feel comfortable to contact me if any question. May the friendship between Taiwan and Vietnam as good as the 2 excellent and cute badminton players. Thank you. Cảm ơn mọi người.
Thank you. Dr. Hsiao, I have a question.
Yes,
Yes.
can everybody hear me?
Yeah. Among the cases that you have performed in the clinical trial, do you think that these data are sufficient to publish, or you need to perform more clinical data?
Yes, this is a very good question. Thank you. I think this question is the number is still too small.
Mm-hmm.
Ideally, I should have about 30 to 30. In total is 60 cases that might be more sufficient to prove the conclusion.
So your study is also IRB approved in KCMU, NCKU?
It's ongoing.
It's ongoing.
Yeah, but because we are trying to make the plan and our study more completely. So we have to discuss more after this conference. because there may be some very interesting questions we can refine or do some adjustment to our plan. So we will bring it up later.
Okay, so if ACRO can help to support you to finish your clinical study, we can have a meeting after this.
Okay.
Yeah.
Sure. Thank you very much.
Thank you. That's a wonderful study.
Thank you, Chairman Hsiao. Yeah. I hope this conference can establish some trends, maybe to gain the support from the company, and also the trends may be applied to the Vietnam University. Yeah, and Dr. Hsiao, I see there's some question on the children.
Yes.
The first is actually from myself. My question is about is there any size limitation for the collagen membrane to apply on the oral mucosa to cover the wound? And Chairman Hsiao has answered the question. Is the largest size of a collagen matrix is 10 by 15 centimeters square. But my question is actually based on the clinical consideration. Is there any further preparation, like the consideration of blood supply or some preparation for the membrane to be used?
Actually,
if it's a very large one.
It might be a consideration too. Yes, sure. But the size limitation, I think, because although there is the largest size is 10 by 15 centimeter, I think it's very large. Sometimes we use a smaller one and maybe two patches if the size is not as large as 10 centimeter, maybe about 5 centimeter or 6 centimeter, we can put two different sizes of the collagen matrix together. And the main idea of the application of the collagen matrix might depends on the wound texture, or I should say the wound base condition. Now, the cases I have presented is almost in buccal mucosa and sometimes in gingiva. But if the defect involves like cortical bone or cancerous bone, because I have no experience about that type of wound. I don't know the wound healing on the cancerous bone with collagen matrix will be. So I might have to think about and have some cases and maybe try to use the collagen matrix in some cases with maybe very small collagen, very smaller cancerous bone defect, or in the hard palate, there is a cortical bone exposure. Yeah, because even without the collagen, I think the wound will be closed secondary. Yeah, and maybe with the collagen matrix, the wound will heal more smoothly, and the patient will feel more comfortable. Yeah,
Yes.
that's my thought.
And I'm sorry, we still have a second question.
Yes.
Can you just answer briefly? Dr. Helen say, dear Dr. Hsiao, are there any differences between a cross-link and a non-cross-link collagen matrix? This is a very special question.
May I answer the questions? Normally,
Yes.
we don't do cross-linking in our collagen matrix. There is the original form of the skin. And people tend to do chemical cross-linking. That's because they purify the collagen and then reconstruct the structure by fibrillogenesis. And that's why you need to have the chemical cross-linking agent to make the structure strong enough to sustain the degradation. But our collagen matrix is decellularized and its original skin form. So the scaffold structure remains intact. You do not need to add any chemical cross-linking. It's already very strong. So that's the answer.
So maybe this only apply to some synthetic
Right.
collagen membrane, right?
That's right. Yeah.
Okay. Thank you very much.